Good evening. My name is Carter Namath, and thank you for stopping by. I was just having supper with Cam and his wife back there, and we were talking about the neurophysiology of stuttering, and I thought it'd be important to share it with everyone. So first, what exactly is stuttering? So, as classified by the NIDCD in 2017, stuttering is a speech disorder characterized by the repetition of sounds, syllables, or words, the prolongation of sounds, and interruptions in speech known as blocks. It's important to note that stuttering is not a disease, rather is a symptom. However, the term stuttering has been used to refer to both the disorder and the symptom. So stuttering is typically a result of genetics, which are passed down between generations, meaning that it runs in the family. It's also interesting to note that stuttering affects male 2 times more than females on average. So as we were doing our research, we discovered that many different researchers had many different theories as to what exactly caused the stuttering, and we'll discuss all those below. First up is the Brocaeus area. So this area is an important part of the neural network for speech production due to its role in planning fine motor movements, which are necessary for speech production. It's hypothesized that gray matter development in the Brocaeus area is abnormal in people who stutter, specifically the pars opercularis region. So as we grow from an infant to an adult, typically our brains get pruned as we learn, meaning that the thinning of our frontal gray matter through ages of 7 to 16 is related to improved verbal learning. Now, in one study, it was found that the pars opercularis region was abnormally thick in both children and adults who stuttered, suggesting that the thinning of the gray matter is crucially important for the development of fluent speech motor control. Suspect number 2 is the supplementary motor area, which I will refer to as the SMA. So the SMA integrates information from different neural circuits and manages information about motor programs such as self-initiated movements, motor sequences, and motor learning. It is essentially the hub. In terms of anatomical and functional subdivisions, there are 2 areas. The first one being the proper SMA, which is posterior and is mainly connected with motor structures, and then the pre-SMA, which is anterior and is connected with the prefrontal brain regions used to transmit information about the cognitive aspects of motor programs and higher order processing. So because the SMA complex is part of a timing network, which plans and executes voluntary motor programs, for speech to work effectively, both areas need to work together efficiently, which in turn affects the motor speech programs. So next we will look at the inferior frontal gyrus. So in previous studies, it showed imbalanced activity of these 2 brain hemispheres in people who stutter compared to fluent speakers. So the left frontal brain is hypoactive and the right hemisphere is hyperactive. So when the left inferior frontal gyrus processes the planning of speech movements in harmony with the left motor cortex, which controls the actual speech movements. So when that and the motor cortex are affected, a person is able to speak fluently. In terms of the right hemisphere, when the right hemisphere is overactive, it hinders other brain areas that are involved in the initiation and termination of movements. As a result, the brain doesn't get cued properly to stop at the end of what the person is saying, causing the person to stutter. Lastly, we will look at here the basal ganglia. So there are strong indications that the basal ganglia thalamocortical motor unit through the putamen to the SMA plays an important role in the pathophysiology of stuttering. So dysfunction may have various causes and may be the effect of the interaction between several factors, such as high density of D2 receptors, low D1, D2 ratio in the putamen, aberrant levels of dopamine release, and focal lesions in the basal ganglia thalamocortical circuit. The core dysfunction of stuttering is suggested to be the impaired ability of the basal ganglia to produce timing cues. Some of the conditions that temporarily alleviate stuttering are proposed to be effective by providing compensatory timing information. This pertains to the rhythm effect, the core of speech, and singing. The adaptation effect is mainly based on an improvement of the basal ganglia timing cues resulting from practice of speech. So in terms of treatments, there's essentially 2 kinds of treatment interventions that have shown efficacy. There's medication and there's speech therapy. So medications, symptoms worsen with dopamine agonist medication, thus showing that we should be working with antagonist medication. So although dopamine blocking medication has shown the most efficacy, they can be limited by their side effects. For example, the first generation medications such as haloperidol improve fluency by increasing brain activity in speech areas, but had low tolerability due to dysphoria, sexual dysfunction, and tardive dyskinesia. And the second one is speech therapy. So it ranges from non-invasive like speech therapy and EMG feedback to maximum invasive like deep brain stimulation involving electrodes. So in terms of the most effective, no medication is yet FDA approved for safe use. It's hypothesized that for one reason for this is no company really has the hundreds of $1 millions to push it through the FDA process. The most consistent treatment modality was intensive smooth speech therapy paired with EMG feedback, which decreased stuttering by 85 to 90% across all assessments contexts and showed a better immediate long-term results. I got to get back to dinner here with Cam and his wife, but thanks everyone for your time and have a good rest of your evening.